Hello, everybody. My name is Alexa Tinsley. I am the Director of Programs here at Jett Foundation. Thank you all for joining us for our community webinar series on PJ Nikoloff's steroid protocol today. We're going to go ahead and get started in just another minute, but I do want to allow people to hop on. As you are hopping on, if you are willing, please put your name, where you're from, and you or your child's age in the chat. That would be wonderful, and we will be back in just a minute to let people come in the room. So thank you guys for being here. We appreciate it. All right. It looks like everybody, at least everybody that is here. So I will go ahead and get started. Again, my name is Alexa Tinsley. I am the Director of Programs here at Jett Foundation. We all appreciate you so much joining our webinar series today on PJ's protocol, and we can't wait for you to hear from our amazing facilitator and our amazing panelists, and they are going to go ahead and discuss PJ's protocol with you today. Before we get started, I do just want to mention a few things. If this is your first webinar series, we do offer these throughout the year, but it is being recorded. So if you have to log off for any reason, lose connection, anything that makes you miss this webinar, it will be recorded and in our library of resources on our website and YouTube that you can watch later. After the presentation, we will be answering questions. There is a Q&A box for me. It's at the bottom right-hand side of my screen. So if you have any questions throughout the webinar, feel free to drop them into that box. We do monitor the chat and we do monitor Facebook. So we will try to get to all of the questions. We are sorry if we miss any, but we do try to look at those questions that come in through the chat and through Facebook to get those answered. If for any reason we are unable to answer any with the time that we have, we will go ahead and send them to the panelists and try to get you answers after the fact as well. So I'm going to go ahead and introduce our facilitator and panelists. So Julie, you could go to the next slide, please. So our panel facilitator today is Kathy Connett. She joined PPMD in 2012, has over 25 years of experience as a nurse, majority of which were at Cincinnati Children's Hospital, and she has cared for more than 300 families living with Duchenne muscular dystrophy and other rare diseases as well. During her time with PPMD, Kathy developed and directed PPMD's Certified Duchenne Care Center program. I think we all know what that is by this point. And she has helped the US and the Certified Duchenne Care Centers provide comprehensive cares for Duchenne. She was also part of the team who originally created PJ's protocol. So if anyone is an expert in this subject matter, she definitely is. Next, please. So one of our panelists who will be on with us shortly is Brian Nikoloff. Brian is a parent of 2 boys with Duchenne. One of his sons, PJ, passed away in 2013 at the age of 31, which highlighted the need and the creation of PJ's protocol. Justin is 36 years old and lives at home with Barb and Brian, and they have been actively involved since 1987 with MDA, PPMD, and most recently us here at Jett Foundation. Next, please. We also are very excited to have Dr. Anne-Marie Sprocki here with us today. She is an associate professor in pediatrics at McGill University Health Center in, I believe, Canada, correct me if I'm wrong, and is the division director of pediatric endocrinology. She's active in teaching, advocacy, and clinical research, and her work focuses on the comprehensive care of children with complex care needs, such as Duchenne. And she will be talking with us about the endocrinological aspect of PJ's protocol today. Next, please. Another panelist for us today is Gloria Orozco. I probably pronounced that wrong, so I apologize. She is a mom of a 12-year-old boy with DMD. Her 14-year-old nephew also has Duchenne, and she is a manifesting carrier, as well as her 14-year-old daughter and her 2 sisters. Gloria has dedicated herself to raising awareness since 2012 when her son and nephew were first diagnosed, and she often serves as a liaison between people and organizations to improve the quality of life for individuals and families affected by Duchenne. Next, please. We also have Amy Akins. She has been led to her current professional path from her experience as a mother to a young man with Duchenne. She has worked in various capacities within both public and private nonprofit organizations focused on serving individuals with disabilities. And in her current role as Director of Patient Access with Little Hercules, Amy tackles treatment access concerns through extensive engagement with a variety of stakeholders, as well as involvement in various groups and projects focused on access issues within the rare disease community. Next, please. And last but not least, we have Ruth Bodenheimer. She is a homeschooling mom to 5 children, one of which is her 10-year-old son, Zeke, who has Duchenne. Zeke is a complex medical case, having been born with gastroschisis, working on that one, followed by his Duchenne diagnosis at 9 months old. In her free time, Ruth enjoys connecting with other Duchenne families and sharing her experiences as a caregiver to a child with Duchenne, and that is what she's doing here today. So with that, I want to thank everybody again for being here, and I will hand it off to Kathy.
Thank you so much, Alexa. It's my pleasure to be here. PPMD has worked closely with Jett for many, many years, and I've worked closely with the other panelists many, many years, and it's a pleasure to be here and share this information. So I thought I'd start off with talking about why stress dosing is important and what cortisol really does in your body. So what does cortisol do? So first of all, if you're under stress, your body goes through a fight or flight reflex. And part of that fight or flight reflex is to have the hypothalamus release corticotropin releasing factor. That should be CRF. My apologies. So once the hypothalamus releases corticotropin releasing factor, that stimulates the pituitary gland in your brain to release adrenal corticotropin hormone. You don't have to remember any of these things, but those things tell the adrenal glands to increase the cortisol level in your body. So if you're normally under a stressful situation, your body goes through this whole hormonal series, and your body releases enough cortisol that you can deal with the fight or flight reflex, whichever your body chooses to do. But it has to have that increased level of cortisol in order to be able to deal with the stress. So next slide. So what happens if you're taking steroids? Well, if you're taking steroids, your body just kind of says, okay, those steroids are coming from someplace else, so my adrenal glands can kind of take a little nap, and while they're napping, they don't have to respond to stress, they don't have to release daily cortisol, because your body knows that cortisol is coming from somewhere else, which is great as long as you're under normal stress levels and your body just has to utilize the amount of cortisol that you get or cortisone that you get from your daily dose. But when you go through a crisis and your body is under stress, your body needs extra cortisol, and that if you're not getting that extra cortisol, you will have inefficient cortisol to deal with the stress. And then all of your organs in your body are trying to make up for that lack of cortisol, and that response can be life-threatening. Next slide. So what we tell patients is if you are vomiting, then you need to pay attention to how long you've been vomiting and how long you've been without your cortisol. So if you usually take your cortisone in the morning and you are vomiting and then you stop vomiting a couple of hours later, then you can take your dose of cortisone when you stop vomiting, if you've been not vomiting for about an hour, and then the next day resume your normal courses of normal dosing of cortisone. However, if you've been vomiting for 24 hours and you're about to miss the second dose of cortisone, then your body's going to start to wonder where that cortisol is. If you're about to miss the second dose of cortisone, then you need to go to the emergency room because you're at risk for adrenal crisis. Don't have to worry really about what kind of cortisone you're taking. If you're taking deflazacort or prednisone, the ER is equipped to figure out what IV dose you need from the oral dose of medication that you take. So all you have to do is let them know what your normal daily dose is, and they can figure out what your stress dose needs to be or what dose you need. You do need to often remind the staff that that high liver enzymes are normal in Duchenne, and so they don't need to be worried if your liver enzymes come back high. The only thing that you need to worry about is getting that cortisone in. Next slide. At this point, I'm going to hand it over to Dr. Subraki, and let her talk about why cortisol is important and why stress dosing is so important. Annie?
Thank you, Kathy. It's a real pleasure to be here. So, cortisol, what is cortisol? So, cortisol is that hormone, as Kathy mentioned, that's released by the adrenal gland. And what it does, it really is important to keep our blood pressure at its normal level day to day. It helps keep our sugar at its level it should be day to day. And it basically helps with all of our body functions. And as Kathy mentioned, if ever we're stressed, back in evolutionary times, if we'd be running away from a bear or a lion, our cortisol levels would skyrocket, and then we'd have more energy to get away from that threat, if you will. We don't have bears nowadays, unfortunately, or maybe we do, maybe in Canada, but I don't know about near where you guys are. But at any rate, it is so important that if there's a lack of cortisol, then you can imagine the blood pressure will decrease, the sugar will decrease, and so the individual could potentially then have a seizure. There could be obviously worse comas, and then the final stage would be death. So it is quite important that the body has enough cortisol day to day, but more importantly, when there's a stress. So that is why it's so important that we have this seminar today, because I suspect many of the individuals pertaining to this session today are on some type of steroid. And just as a reminder, when we talk about steroids, we're talking about glucocorticoids, so gluco for sugar. And that's because this is the type of steroid that is so important for blood pressure and blood sugar regulation versus the steroids bodybuilders might take. That's a different type of steroid.
Thanks, Dr. Zabrocki. Next slide, please. So the initiative to develop PJ Nikolov steroid protocol was brought to PPMD by Brian Nikolov, and the history that he had, the story that he has with his son PJ. So Brian, can you maybe talk to us a little bit about what that story is? You might be muted, Brian.
You are. Let me see if I can ask him to unmute.
Sorry, what's a webinar without technical difficulties, right?
It's true. In the age of computers, it wouldn't be fun without some. So,
Hello?
there he is.
Hello?
We can hear you.
Hi, everybody. I am so, sorry. I don't know what's going on. I apologize.
No problem. Brian,
Can anybody hear me?
Yes, we can. We thought maybe you could talk a little bit about why you came to PPMD to develop the protocol and your story with PJ.
Okay, thank you, everyone, for participating in this, and I apologize. I don't know what's going on. I really don't. I'm on my phone, but I can't get any video. I can't use my PC. I don't know what's going on. Anyway, PJ's protocol was written in concert by Parent Project and St. Vincent Hospital here in Indianapolis. Our son PJ passed away in November of 13, and it was after he had surgery for a broken hip and humerus. And the pills that we gave the hospital, the deflazacort that he was on, were not given to him after surgery. We did not find that out until we arrived home after he passed away and noticed that the pills were not given to him. So that created the adrenal crisis or whatever it may be. He had surgery on a Thursday, and by Saturday he had a heart rate was all messed up, his temperature, etc. Confusion. They thought it was ARDS. They thought it was pneumonia. They weren't quite sure. So I got a hold of, and I apologize, I got a hold of Dr. Mendel after this happened, and I gave him the symptoms and all that, and he said, well, it sounds to me like steroid deficiency, et cetera. So we got the medical records, which took a while to get. I gave those to my personal physician, and they did locate that the dosage was not only stress dosed, it wasn't even given. He was on 51 milligrams a day of deflazacort. He was on prednisone for years before. He was on 51 milligram, and that was not given on a Friday and Saturday and Sunday, and by then it was almost too late. So the protocol was written due to the fact that Dr. Mendel suggested I get a hold of Parent Project, talk to Kathy and Pat. And basically the protocol, as we all know, is a set of directions. And I talked with the hospital regarding that I wanted it to be a win-win-win, that all the physical or the medical professionals at the hospitals would understand about stress dosing, when to apply it, et cetera, with all the symptoms. And I'm sure that Ruth and Gloria and Amy can share their thoughts on this too, along with Kathy. But I didn't want this to happen again by, I guess you'd say, maybe an oversight by staff. Now, I don't know if the stress dose would have helped PJ at that time. He did break every bone in his right leg from heel to, or from ankle to femur a couple times. And he was obese, bones were brittle. He was 31. His fraction was already down to 25 or 28. So he was suffering to a degree as it was. But it sure came as a surprise to us because, you know, he's been through this several times and it wasn't an issue. He came out of surgeries all the time, anesthesia, et cetera, no problem. So this came as a total shock. So the protocol was written due to that fact, and it explains. I think it's 6 pages worth or something like that, and it explains of you know, the process, the procedure to go through with the stress dosing, or even a what do they do in that comparison? I can't even remember now if you're on a different drug or different dosage of what the stress dose would be. That's all I can contribute at this time.
Okay, thanks, Brian. Next slide, please. So Brian came to us and as he said, wanted to not have this happen to anybody else in the future, and not to have any parent or any child go through what PJ went through. So we're eternally thankful for him. My first step was to develop a team. So we developed a team with St. Vincent's, Dr. Zeitler from Colorado, Dr. Bowden from Nationwide Children's, Dr. Bigger, who was from Canada, and I'm sure Annie knows him, Dr. Mendel and Dr. Ann Connolly. So with this expert group, we pulled them together and developed the protocol. Next slide, please. So I will talk about what's in the protocol, but what's really important for parents to remember is that you have to have this protocol with you. And the protocol is available on the PPMD emergency app. It's available on our website. I know it's available on the Jett website. It's available in multiple languages. The deflazacort, as Brian said, prednisone conversion is on the protocol, as well as appropriate stress doses of all of those medications. Symptoms of adrenal crisis, just in case the ER is not familiar wherever you are, and exams and tests to evaluate adrenal function, to evaluate whether stress dosing is actually necessary if the ER is questioning that. Next slide. So the contents again of the protocol are information on corticosteroid conversions, the definition of the HPA as suppression, which is adrenal crisis. So all of the symptoms of adrenal crisis, as well as prevention, recommendations for discontinuing steroids in case people wanted to stop them. I think everyone on this webinar knows not to start them abruptly, because your body can go into adrenal crisis if you stop them abruptly. So recommendations for how to do that safely are included in the protocol, as well as risk factors for adrenal crisis and how to evaluate, which I think is what I just said on the other slide. So I'm sorry. Next slide. PPMD submitted the protocol for publication. It's included in the 2017 CDC care guidelines for Duchenne. It's been disseminated on multiple websites. So PPMD, Jett Foundation, I think it's on TreatNMD's website in multiple languages. It's on the MDA website. So If you Google PJ Nikolov steroid protocol, you should be able to find it on multiple websites with no problem. It's included on social media. Again, it's on the PPMD emergency app. We've had workshops ad nauseum, and this being another one, which is great because I never hesitate to reach as many people as possible with this information. Welcome packets, and it's included in all the CDC certified Duchenne care centers that PPMD has. So any of the CDCCs have little emergency cards, and a link to the PJ Nikolov steroid protocol and recommendations for steroid replacement and stress dosing are included. Next slide. So again, there is a publication, and that was our effort to try to reach as many people, as many academics and providers and parents as possible. So this publication is available widely. Next slide. So at this time, I think Gloria and Amy and Ruth have all had experience with this protocol, and I'd love for them to share their experiences with you and let you know how they were able to access the protocol and how the protocol helped them. So Gloria, do you think you could start?
Yes, ma'am. Thank you. Thank you, Kathy, and everyone. It's an honor to be here today, and want to express my gratitude to Jett Foundation for the invitation to be here, to Brian. I'm going to start with a little bit who I am and what I've been doing. And my nephew and my son and my daughter, they got diagnosis back in 2012. Later on, we discovered that the whole family, we were affected by DMD as well. My mother, my two sisters, my daughter, and me, we are all carriers of DMD, and 3 of us, we are symptomatic, and two of my mother and my sister, they not. Right after diagnosis, we discovered that my little brother, who let's see, we discovered that my little brother, per his symptoms, that he did have a DMD too, but unfortunately, he passed away at the age of 5 years of age. And this was due to complications with anesthesia after a simple tonsil removal surgery, because his anesthetic agent, it was something that was not a, well, now we know, that it's not a, recommended for DMD patients. All this happening, and it's interesting, they how something as devastating as a diagnosis for DMD, it gives you inspiration to help others. My son was born in this country, and I can say that he's privileged to have access to a lot of services and medication and good care, but this doesn't happen for Latin American countries. There is where I started to, I asked Kathy and PPMD if they allowed me to do some information in Spanish for the Spanish-speaking families. They allowed me, they helped me to do that. And one of the first documents that I translated, it was the PJ protocol. And why PJ protocol was very important for us is because about at the same time that my son started with corticosteroids usage, the PJ protocol came out. One of my concerns, it was all the side effects the corticosteroids can bring to a patient with DMD. And so I read the whole thing, and I knew in my heart that it was very important for me to disseminate this information with the Spanish-speaking families. And so my focus is being with this Spanish-speaking population is to disseminate all the information possible, starting with the standards of care. But I really focus because what happened to my brother, and because my son was using steroids, and then I saw, unfortunately, some lives lost because of the lack of information. So I done the translation for emergency information regarding anesthesia, fat embolism syndrome, and PJ protocol. And I invite and encourage all clinicians, all the medical professionals to discuss the PJ protocol upon prescribing corticosteroids. I think it's very important if we're lucky and we go to our family to a certified Duchenne center, you get all that information upon leaving the clinic. You know, you start in corticosteroids, they give you Dr. Sealer, give you all the information regarding the protocol and how to be safe while using steroids. So I encourage the families as well to download the information. And for them, it's very important for me to every single family to know that this is a life-saving document. It's something very important. I recommend them to go to the official DMD organizations, PPMD, Cure Duchenne, Jett Foundation, and find this information, download it, and keep it with you, and take it with the doctor when you have UN for whatever reason in the emergency room. So I'm a strong advocate for PJ protocol, for all the emergency information, because this, we know, save lives. And we don't want to see like what happened to PJ or to other families to happen again. We want to prevent more lives lost. It's already complicated to deal with DMD, and but it's very important to have this information in hand. So that's about it, Kathy.
Thank you, Gloria. You've been so helpful and so critical in organizing all of this information in Spanish. And we can't thank you enough for all the Spanish speaking families that really, really need this information and have it thanks to you. So thank you so much.
And if I may add something else, is thanks to Kathy and Brian Nikolov, the PJ protocol is already, and I'm so proud of you, Kathy and Brian, is already in the Centers of Disease Control. Mm-hmm. It's already in the National Health Institutes of Health, and in so many other scholar medical publications. And this is very important for the clinicians, if we have any participating of this webinar, to check this information out. Is of vital importance for our community.
Thank you so much. Thank you. Amy, I know you have a story about your son as well, and we'd love for you to share that.
Okay, thank you. So good afternoon, everyone. I think many people know me either through my work with the Little Hercules Foundation or as a fellow DMD parent. I'm here today speaking as a mom about my family's experience, and I'm really thankful and want to thank the Jett Foundation and Brian for having me on this webinar. I also got permission from my son, Elijah, who's 19 right now. He gave me permission to share his story. And I'm very glad he did. So a little bit about what happened with us. When Elijah was 13 years old, one mid-December afternoon, he fell. And he fell while he was walking down the carpeted hallway of our home. Since he'd been slowing down, falls really weren't anything new to us. I think a lot of folks probably on this webinar identify with this. We thought he'd be sore for a day or two. He'll get right back on his feet. That's pretty much, what was the usual scenario. And we'd grown accustomed to it. Unfortunately, this time for this fall, that was not what happened. Several hours following his fall, Elijah was still in a lot of pain and he couldn't bear any weight. I felt him and he felt hot to the touch, and he began to stop making sense when he was speaking. He appeared to be passing out mid-sentence, and then he'd come back to us, and then he would pass out again. I remember looking at my husband kind of frantically and yelling at him, "We need to get to the emergency room now." I think his leg's broken and he has an FES. I just blurted that out of nowhere. For those that don't know, FES stands for fat embolism syndrome, which can be a life-threatening emergency resulting from fracture. And I was pretty aware of this potential just because very recently, prior to this, I'd been talking with a very good friend of mine who dealt with this with her son. And it was just by chance. We'd recently discussed it. As we resided in a rural community at that time, my husband and I, rather than wait on an ambulance because it would have been significant, we carried him into our personal vehicle and we transported him right to the emergency department a few miles from our house, which was our local hospital. Upon arriving at the local emergency department, Elijah had a very high temperature. He had fast breathing and his heart rate was also extremely high. All symptoms that we just talked about here a little bit in this webinar. His pulse ox was somewhere in the mid to upper 70s, I think. I do remember them nonchalantly just asking me, "Oh, so what's his normal pulse ox rate?" And my response at that time was 99. And at that point, they became very concerned. He was immediately put on oxygen. They did some blood work and x-rays were taken. After the x-rays were read, we were informed by the hospital staff that he had 2 fractures in his femur. I knew all the steps and all the things that I should have asked, but I'll be honest, I kind of went into a shock of some sort and completely spaced out and forgot all of it. So I started, messaging friends of mine. I messaged one particular good friend who said, "You need to contact Kathy at PPMD. She'll know what to do." It was a weekend. I remember dialing that number for Kathy and leaving a message, and then she called me back pretty much almost immediately. And Kathy, I remember her saying, "Breathe, Amy, breathe. You can do this." And we discussed the next steps that I was going to take, and I was going to take charge. So then at that point, she also connected with Elijah's pulmonologist. Following the call with Kathy, I requested the emergency steroid dose multiple times. The rural hospital doctor, he refused. His reason for refusal, he cited that my son had a high white blood cell count, and adding steroids would only make things worse. At that point, I demanded a transfer to the hospital where our clinic is. Immediately upon arrival there, I told the ED staff that he needed a stress dose of steroid and that the rural hospital had refused to do so. I also told them that I feared fat embolism syndrome, also known as FES. I provided them the information on PJ's protocol, which I located on the ambulance ride down there. And they administered the dose immediately. Following that administration, it was like night and day. His stats and his appearance vastly changed for the better very quickly. We later found out that he had not 2, but actually 3 fractures. FES was ultimately diagnosed on the afternoon of day 2 of his hospitalization. And they did tell me they would have never even looked if I'd not been insistent on the possibility of that in their ED. Nobody on his inpatient medical team there, even at our major hospital, had experience dealing with an FES. And one doctor even told me they only cover it in their training when they're discussing things like multiple injury car accident trauma or major orthopedic surgery. And it is extremely rare in children. However, we do know that those with DMD are at higher risk because we already have the weak bones, and it's, further even more weak because of the steroid use and the risk of fracture. So over the course of Elijah's hospitalization, I shared that protocol with as many physicians as I could. Some of them even took down a link so they could review for themselves and have the protocol available should they need it again. We were at a major hospital, and while they were familiar with stress dosing, they were not aware of PJ's protocol, and they just didn't know it existed prior to me showing them. During the hospitalization, they implemented it as written. 3 days into admission, Elijah's heart rate finally returned to normal. What a relief. He was released a few days after that. If it hadn't been for PJ's protocol, we might have had a much different outcome. And I think we've heard about what that much different outcome might look like. We as parents were often forced to advocate for our kids' needs when medical staff fail to recognize them. Sometimes they don't believe us. I just want to say we can't be afraid to keep pressing the issue when we know something is needed for our kids. Had I not pressed at our local ED, they probably would have admitted him to our local hospital where they would have continued to refuse to stress dose. And while this was the end of walking for him, Elijah survived, and that's really important. Prior to this experience, we did everything we could to keep him walking. It took knowing that I very well could have lost my son on that mid-December day to realize that losing that ability was not the end of the world. Life has gone on, and it's a pretty amazing life. We've stress dosed multiple occasions since this instance, and Elijah's endocrinologist has prescribed a stress dose to be injected at home should the need arise. We do what we can here at home to avoid fractures, such as avoiding physical lifts and making sure we rely on equipment, because using that equipment just, let's face it, just makes everybody safer. Thank you all for letting me share my story.
Boy, Amy, so it's one thing to be stressed, but to be stressed and have to be the expert in the room, right?
Absolutely.
Word. I want to absolutely stress what you said about using equipment, and also seatbelts. If your guys are in something that's got a seatbelt, there's a reason the seatbelt is there. So please use the seatbelt, right?
Exactly.
Thank you so much. Ruth, I think you have an interesting story and a unique story that's that you'd like to share as well.
Yes. Thank you for having me. So Zeke is 10 and he was born with hysteresis. Alexia did great. It was where his bowel was outside of his body.
Ruth, do you have a computer on as well?
It is on my computer. Let me try a different one.
Because we're getting feedback.
How about now?
Much
Is that
better.
Okay. So he was born with his intestines outside of his body. It's still doing it, isn't it?
No, it's not as bad. I think you're all right.
Okay. And then a little bit later, like 6 months later, he was diagnosed with Duchenne during a hospitalization. And then everything fell apart because we didn't know what was going on with everything. Like most families when you get a diagnosis like that. And then in 2017, I was able to get Zeke into the vamorolone trial, the initial one, where we dosed for safety and dosage amount. And shortly after that, about 3 weeks in to taking vamorolone, Zeke had to have emergency surgery. I mean, we were at the airport getting ready to get on a plane to go to our trial clinic, and we had to leave the airport. We were literally at the gate and ran to our hospital, and he had surgery. And after that, I went to our team. I was like, hey, do we know if vamorolone is going to cause adrenal crisis? At that point, I had heard from Brian. I think he had been passing around PJ's protocol on all the Facebook groups and support groups. And so I was kind of aware of it. And I just was like, okay, so what is this going to be? Because Zeke has a history of crazy things happening and ending up in the hospital. And they gave me PG's protocol. And then in 2022, Zeke had a vaccine reaction and a viral infection going on. And he started vomiting, which is normal for Zeke. We've been admitted many times. I'd stress dosed him many times. The hospitals had always stress dosed him because I'd show up at the ER and be like, hey, my son is on a steroid trial. He likely is going to have an adrenal crisis if we don't stress dose him because he's unable to take his dose, and his vomiting is extreme. I mean, his body goes into super stress with how much vomiting he has. So in 22, I showed up at the ER because Zeke just would not stop vomiting. At one point, I was able to give him a stress dose orally, and he kept it down for 30 minutes, 40 minutes. And I thought everything was fine, but it wasn't. He just spiraled out of control. And we lived rurally like Amy. We were an hour and a half from the hospital. So I jumped in the car and we drove all the way there as fast as we could at 2 a.m. And I showed up at the ER and I said, my son has Duchenne. He's probably going into an adrenal crisis. And they got me in really, really fast, and all the doctors came back, and I pulled PJ's protocol out of my bag and handed it to them and said, this is what we need to do. He needs to be stress dosed, and you need to do labs to check for an adrenal crisis. And the hospital was great. The ER doctors ran all around trying to figure out what to do and what dose to get him. And they did. And it took about 18 hours for him to go back to normal. And I attribute it all to having PJ's protocol right there and handing it to the staff. And they knew exactly what to do when they got that paper. In the past, they didn't know what adrenal crisis was, or it wasn't something that was stressed or easy for them to look up and find. And so PJ's protocol has made a huge difference for that. And after that, I went and talked to his endocrinologist about how it went so fast that he ended up in adrenal crisis, even though he had a stress dose orally and kept it down for 30 to 40 minutes. And because of Zeke's complicated nature, she said that most likely his body just wouldn't absorb it fast enough. And there was just so much stress. And that's what had happened. And at that time, we really went over like when I should be stress dosing him. And with his injectable his hydrocortisone dose, Solu-Cortef. And she gave me multiple IM doses so I could keep one on him wherever he was and one in my bag wherever I am, for future if this happens again, which we've ended up in the hospital multiple times since then for the same kind of ordeal, but he has not gone into adrenal crisis. And I've always had the protocol ready, and I just show up at the ER, and that's what I start with, that my son is likely going to go into an adrenal crisis. He has Duchenne muscular dystrophy. And because of his other complications, I've mentioned that first. And that really gets everyone at the ER running around and getting him in, because we don't want to waste any time. It's a life-threatening condition. And I know I've talked about that in several of our support groups and really pushing that, because so many neurologists prescribe steroids and they don't talk about stress dosing. I mean, in our conversations with taking steroids, I've had multiple neurologists and even endocrinologists that never brought it up to me. And now, of course, I go in and I talk about it with any endocrinologist, any neurologist, everything like that, because going into an adrenal crisis is not a pretty thing. Like Zeke, I've never seen Zeke in so much pain in our life. And it was the first time that I actually was nervous, and he's been hospitalized probably 30 times. And I think that's about it.
Oh, I can't imagine how scary that was for you. Good for you. I'm really glad that you're out there advocating, Ruth. It really is the parents who are the squeaky wheel and really need to get that information out. Dr. Sprocky, so we're going to have so many more patients that are on vamorolone. Can you talk a little bit about vamorolone and stress dosing, what needs to happen, and why this is so important?
Yeah, so vamorolone is a steroid. It kind of came out as a new kid on the block, and it was supposed to be this new wonder drug that's not a steroid. Well, actually, it is a steroid. It's just not a classical steroid. So the idea behind vamorolone was that it was supposed to retain the anti-inflammatory property of your classic glucocorticoids like prednisone or deflazacort, but it was supposed to have less side effects. Well, guess what? It still has the side effect of adrenal suppression, particularly the doses of 6 milligram per kilogram, which is, I think, the standard of care for most individuals now that have transitioned or have started on vamorolone for Duchenne. So it certainly does cause adrenal suppression. So absolutely, with anyone on vamorolone, there needs to be the use of a protocol like PJ's. There should be the intramuscular hydrocortisone on hand at home. There should be all of the extra stress doses of even just hydrocortisone pills, so that when the child or the individual is sick, that they take that in addition to their vamorolone. So it's incredibly important that we get the word out, because I don't know necessarily if all the neurologists now who are prescribing the vamorolone are aware that it is a non-classic steroid and indeed can cause adrenal suppression. So certainly in the community, the endocrinologists that are involved with the individuals Duchenne muscular dystrophy, we're working very hard to get some new documents out there in the medical communities so that we can increase awareness that vamorolone is one that also causes adrenal suppression.
So what should you stress dose with?
Good question. So I believe that all of these children should, or individuals, I follow the children. That's why I keep saying children, but I am aware there's probably some adults on the call. But these individuals should have hydrocortisone or Cortef at home, given at least twice a day, maybe up to 3 times a day in the event that there's a fever or there's any kind of stress on the body. And of course, vomiting, you need to absolutely have that intramuscular dose at home. So certainly those on vamorolone should have a prescription for hydrocortisone at home, both IM, intramuscular, and oral.
But not to stress dose with vamorolone, correct?
Correct. So vamorolone cannot be used as a stress medication. It actually has some properties that can actually not be useful at all if you do use it as a stress dose. So do not use it. You can keep using it if you want for the Duchenne part, the treatment part, but certainly you need to add in now hydrocortisone as a treatment for stress. So that's a very important point. You cannot stress dose with vamorolone.
Thanks. That's really important to know. Thank you so much. So one of the next steps for PPMD will be to update PJ's protocol to include vamorolone and the information that's coming out around vamorolone. And Dr. Sprocki is part of a working group in Canada in partnership with PPMD to evaluate steroids and vamorolone and make recommendations around those meds. So thank you so much. I think we have done our presentations, but Alexa, do you have people that have questions that we can address?
I don't have any questions yet, but we do have a special guest, Lucy and Barry Nelson. I'm going to have them go ahead and share their experience. If there are any questions while they're sharing their experience, please go ahead and put them in the Q&A or the chat, and they'll share a little bit about their experience, and then we will get to those questions.
Thank you, Alexa. I appreciate the special guest. I don't think it's more like we relate to the game. I'm Lucy Nelson. This is my husband, Barry Nelson, and we reside in Southern California. We have 2 boys. Our youngest, who is now 15, Henry, has Duchenne muscular dystrophy and was diagnosed right before his 3rd birthday. We are total rule followers. So we were fortunate that he was diagnosed young, and we have listened to everything we've been told. We go to UCLA, the Center for Duchenne, Stan Nelson, Mindy Cameron, our mentor people. You know, there are go-to people that have taught us so much about this community and have always kept us informed on what we need to do in case of emergency. We had been fortunate that we'd not had any major illness, injury, anything with Henry. He'd had a couple small falls with minor fractures starting in 2020, but nothing too traumatic. It just, as a speaker said earlier, it just took a few days for him to feel better. But that all changed in May of 2022. He had a very insignificant fall in our walking from our great room to our kitchen. He was carrying chips and salsa, and his leg just gave out on him. He didn't trip, he didn't fall, he just crumbled. We were trying to get him up to move to see if he would just feel better. My older son, who is 17 now, was 15 at the time. He was home with me. My husband wasn't home. And he was the quick thinker. He was the one, Mom, pull out your app. What does your app say to do? What should we do? He was on the phone with my nephew, who's a paramedic that lives in Northern California. And I was in mom mode. So he was in 911 mode. And based on my nephew, the paramedic, saying, you guys know the drill. You need to get him to the hospital and call 911. And I was, thinking, we'll just put him in the car. Yeah, no, that was not happening. So when the paramedics arrived, I had PJ's protocol up on my phone. I'm showing it to them. They were great. They were reading it. They were completely looking for any signs of FES. Obviously, they didn't know at the time it was broken, but he was in severe pain. So they were wanting to give him pain medication. And I, again, was pulling up everything on the app going, can we make sure we get to the hospital again? You have to be a bulldog. Anyone that came into that room, I'm showing them, this is the protocol. Barry had gotten there by that time. He was on the phone with Stan Nelson. Kathy, we were communicating through IM messages. You really, at that point, you bring in your family and ask everybody, what do we do? Are we doing the right things? They usually don't tell you that the x-ray results. They were in the room and they're like, oh yeah, he snapped it in half. His right femur was broken. They were able to stabilize him over the night, and they chose not to do an emergency surgery that night. And they pushed it till the next morning so that they would be in communication with all of his Duchenne team up at UCLA. We were in Orange County at the Children's Hospital. Everything was going well. Henry had great heart and pulmonary test results. He went in for surgery. And again, we insisted on speaking with the anesthesiologist that morning and made sure they saw all of the procedures and policies. Everything went well with the surgery. After the surgery, we see the anesthesiologist right away, and she goes, wow, I had to give him a lot. He just did not want to, go out. And she goes, and it took me a while to wake him up. And we were like, wait, what does that mean? And it was after the surgery. They'd given him a stress dose upon arrival into the hospital on Thursday, but it was after the surgery, he was having a hard time waking up. They were like, oh, you're going to probably be home by tomorrow morning, and, we'll take him off oxygen and everything tonight. They found that every time they took him off oxygen, his blood ox dropped, his heart rate went down, and it dawned on us, I think, after a little bit, this was a whole new crew of people. So we again had to bring up, hey, has he had it? It took them probably until Saturday morning to realize that although they had been giving him his regular, instead of, his oral influenza, they were giving him intravenous steroid. They weren't giving him the stress dose. So it took us until probably Saturday morning for them to finally realize that. And they started giving, and he wasn't coming to, he was groggy, a little confused as to where he was. And it took them, when they finally realized Saturday morning and they were giving him a stress dose, I think they did it every 4 hours. 4 hours. By Sunday morning, he was completely back to himself. They were able to take, and they were talking on Saturday that he might not be able to go home right away. If he did go home, he'd have to be on oxygen. And we're like, his heart and his lungs were fine before he went into this. And by Sunday morning, they were able to take him off the oxygen. He was back to normal. He was back to being himself. The doctor that was there that day did come in and basically tell us, yeah, we think, it was kind of unusual. He didn't have it before surgery, but after surgery, we think he went into a little adrenal suppression as well as FES. So that we had been very concerned about it all ahead of time. We thought after the surgery, everything would be fine. So that was a huge wake-up call for us, is that you still keep bringing these things up. You still keep sharing all of the information. He got let go from the hospital on Sunday. He improved so much that wasn't easy, but we flew out that Friday to Orlando for the Cure Duchenne Futures Conference. And he was actually able to put weight on his leg and take 2 steps with the PTs that were there at the event, which he is back to being, he's much more afraid now of falling. So he uses his wheelchair more regularly outside of the house for protection, but he is still ambulatory. He walks around the house, is wary of our dog when the dog goes by. But again, we thank Brian for using his experience to push this PJ protocol. And we're convinced that saved Henry's life. And it wasn't the fracture that was going to get him. It was what happened after the fracture and after the surgery.
Thanks, Lucy. I have one that's really important. And I think that the important of being a squeaky wheel again and making sure that this information gets to providers and emergency rooms and anybody who needs it is just so important. And it's available so many places. So if you've got a child or if you are a person who's on regular doses of steroids, just so critical to have this information. Dr. Sprocki, is it possible to give too much steroid? And when do you, I've had ER people in the ER who have said, their docs have said, you're already on high doses of steroids, you don't need an extra dose, or you've had enough doses. So how do you know?
So that was the classic thinking too, even amongst the endocrinologists, when you're on these super physiologic high doses of either prednisone or deflazacort, well, you're on so much, why would we give you more? But it's actually the type of steroid. So they are not equivalent to cortisol. They're in the family, but they're not actually equivalent. And so because of the different way the bodies will metabolize those types of steroids, it's always better to err on the side of caution and actually give what's closest to the hormone cortisol in these individuals, which would be cortisone or hydrocortisone. So, you know, if they were already on hydrocortisone super physiological doses, perhaps they're fine, they're covered, but they're not classically on hydrocortisone super physiologic doses. They're on other types of steroids that are part of the same family, but they are different. So I would always err on the side of caution. And I was going to mention, even for any individual who gets one dose of stress coverage, let's say they're going under the knife for a surgery, it's elective, they should still be stress covered, in my opinion, at least 24 hours afterwards, because it can take a little bit of time to really undergo a stabilization phase. So I think that's a really important thing to advocate when you do have your loved ones having some stress coverage, that it's still ongoing. The other thing I did want to mention is that we've heard a lot about broken bones, and unfortunately that is the reality of glucocorticoids and a side effect of it. So many of the individuals are treated with bisphosphonates, and those can typically cause a flu-like illness, particularly after the first infusion, but sometimes after subsequent ones, particularly if doses are changed. And so more and more, we're also telling our families to give hydrocort, or sometimes you can take the giant dose of prednisone or deflazacort and perhaps divide it into two. So each center may have a different type of protocol they use, but there should be still some sort of stress coverage with bisphosphonate therapy as well.
Thanks for adding that. And it sounds like it's always better to give it than not give it. So if there's a question about whether or not this person needs a stress dose of steroid, it's always better to give the stress dose than not give it, correct?
Correct. I think it's tough, right? Because we all see especially the cosmetic side effects of having so much glucocorticoid in the system. But when you're at the point where you're not well, just give it. It's one extra dose that could potentially save a life.
Thank you. So as we have said before, I think this information is widely available online. It's available on the PPMD emergency app. It's available for print. And if you have a provider who doesn't know anything about stress dosing or the PJ protocol, then print it, hand it to them. You can give them the publication, which will validate the information that's on the protocol, and hopefully everyone will listen. Alexa?
I think you just answered all of the questions. Thank you both. And thank you all so much, panelists. Thank you, Dr. Sprocki. Thank you, Kathy, Gloria, Amy, Ruth, Lucy, even though you're late to the party. So important. So thank you all so much for being here. To all of you on the webinar, we so appreciate you coming and learning with us today. Again, this is recorded, so if you do know of anybody that could utilize this information and that it would benefit, please do share. If for some reason you can't find the recording, please feel free to reach out to me, alexa@jettfoundation.org. And we all know that sometimes it takes time to process questions. So if you do have any questions after the fact, please also feel free to reach out to me and I will get them to our panelists. So thank you all for being here, taking your time out of your day to share your knowledge and expertise with us. We appreciate all of you. Thank you. Have a wonderful day, guys.